Right. Welcome, everyone. This is another webinar of the Global Observatory of Long-Term Care. I'm Adelina Comas-Herrera. I'll be introducing today's speaker, but first of all, I'm going to give you a quick overview of the Global Observatory of Long-Term Care and the next webinars after this one. The Global Observatory of Long-Term Care is a platform for cross-national learning to improve and strengthen care systems and is part of the International Long-Term Care Policy Network. Our goal is to identify key shared challenges and showcase how different countries and localities are addressing them in long-term care by sharing research evidence and facilitating collaborations. And this is aimed at policymakers, industry, advocates, care professionals, and academics. Everyone's welcome. To engage, the best thing to do is to become a member. I think many of you already are members who are joining today's webinar, but if you aren't, I will share a link so you can do that. When you join, you can choose different interest groups. Like today, this webinar is organized by the Quasi-Experimental Research Methods Interest Group, and there are many others. And once you join, that also helps you find other people with similar interests to you. You can also share your publications and events and your knowledge. And you can also subscribe to our newsletter. This is a QR code on how to join, and it takes you to also a link that my colleague Nas will be sharing in the chat. And so you know about our next webinars. We have another one this week on Friday, which is on social protection, inequality, and redistributive justice in Southern Africa, looking at the challenges for elder care. That's from the Social Protection in Southern Africa interest group. We then have another one next week on Monday from the Data Science interest group on enhancing care home quality using wearable tech and social network analysis. And we have one more on quite a different topic from the responses to dementia interest group, looking at rehabilitation services for young onset dementias. And we will soon be also coming up with some of the webinars for the next year. So going to stop sharing, and I'm really pleased to be introducing Bram Wouterse from the Erasmus School of Health Policy and Management at the Erasmus University Rotterdam from the Netherlands, who's going to present on missing the mark, the effects of abolishing co-payments for social assistance in the Netherlands. Bram, it's all yours.
Yeah, so I'm going to talk about a paper which is still work in progress, and it's called Missing the Mark, the effects of abolishing co-payments for social care. This is joint work with Peter Baks and Stijn Koremans, and I saw that Stijn is also in the room, and he actually did most of the underlying data analysis. So if there are any difficult questions, I hope he might be able to answer those for you as well. But I'll do my best. So I think this is a bit of a different kind of paper for me to present, because I think normally when we do a paper, we find some effects, and then my job is to convince you that these effects are really there and that they're credible. I think in this case, the Dutch government came up with a policy for which I think all economists would say, but this will have kind of these and these adverse effects. And we find that this is indeed the case. So it's in that sense quite obvious. So I have to do the reverse. I have to kind of convince you that the policymakers really thought this was a good idea, and that even if we find things that there are a bit expected, that might still be interesting for you. So let's get started with that. Let me see. Yep, there we go. I want to kind of start with a general motivation, and that is that targeting social care is hard. I'm still a bit puzzling about what's the right word to use. I use social care. You could also say social assistance. At least what I mean is we're going to look at assistance for older people. So daily activities, cleaning, helping with doing the groceries, but also supportive devices, transport, these kind of things. And we know, of course, that these can be important for older people, but at the same time, many people can provide for these services themselves. I used to have a boss when I was working at the Policy Institute, and he said, well, old people, they can just sell their bikes and buy a stroller. So there's a Dutch example, but you can see that to some extent there might be some truth in this. So a lot of these things we're used to pay for ourselves. So why can't we do this when we get a little bit older? and with some health problems. At the same time, we also know that some people really cannot provide these services themselves because they either don't have the financial resources, because they don't have the social network. And we also know that for these older individuals, public provision of social care can actually have large benefits, both for themselves in terms of their health and well-being, but also for their long-term care system, because if we provide these services, then we might be able to prevent more expensive medical care or even institutional care or nursing home care. So that means that there is scope for societal benefits by providing these things publicly, but at the same time, there's a huge risk that public provision leads to over-provision of these services. So one of the central policy goals is then to really target these provisions of care very, very well. Now, what do we already know about this? I think when you look at let's say the preventive effect of home care and social care, there's quite some growing literature. So we know from the US there are a number of papers, for example, about home care subsidies and how they can prevent admissions to nursing homes and hospitalizations. We also have some similar evidence for European settings. But at the same time, we see these threats that I was just talking about. And I think you can kind of distinguish between two things that are almost similar. And one is dead weight loss. So that means we might be providing things that individuals otherwise would provide themselves, right? So now we take over the bill, as the government takes over the bill, but actually people would have done this themselves in any case. And the other one is moral hazard, and that means that maybe we were even providing services that people would not be willing to pay for themselves. So we might be really over-providing things above the social optimum. So that means that targeting is very important. There are kind of two main ways to which the government can target these kind of services. So the first one is eligibility criteria. So I think in almost all countries, there are some thresholds to the using of long-term care and home care and also social care. Generally, they are based on disabilities and health, maybe sometimes social circumstances. But what we know is that it's quite hard to kind of capture in these kind of uniform, centralized rules all the things that might matter for someone needing these services or not, right? So there might be a gray area that's very hard to capture in general rules. So often, in addition to eligibility criteria, we introduce a financial incentive, a co-payment. And sometimes it's income dependent, sometimes it's not. And there's a little bit of literature, so maybe I'm overlooking some of it, but there's some recent literature that kind of looks at similar services and the effects of co-payment. So there's a paper by Haga et al. In the Journal of Health Economics, and they look at quite small co-payments for home nurse visits, and they actually find that these small co-payments actually decrease the use of these nurse visits. And there's another paper that I like very, very much. I think it's still work in progress. I saw it at the UHIA conference this year. That's by Hennig Ooyen and co-authors. And they use a kind of stepwise co-payment design for practical home services, very closely related to what we are looking at. So they really have kind of nice discontinuities. I think this is for a Scandinavian country. And they actually don't find any effect at all. So I would say there's still a lot to find out about how exactly these co-payments work and how do they help us or not to target these services to the right target group. Okay, so what I'm going to do in this study, we're going to look at a policy change that reduced the ability of Dutch municipalities to target the provision of social care, in particularly to distinguish between different income groups. And our setting allows for kind of a natural control group, which, so we kind of can make the case that we're looking at causal effects. So we make a number of contributions, I think. So the first one is that we really focus on these very light forms of care or maybe even social assistance, and where this threat of dead weight loss, this over-provision might be particularly relevant. We also look at a specific reform that limited the ability of local payers to target care. So we're doing some combined projects. So I see my PhD student Prithvi is also somewhere in this call. So we're looking also at this relationship between different layers of government that often are responsible for different parts of the long-term care provision. And this is one important element. So the national government tells the municipality, you have to take care of the social care provision, but then it limits the ability of this local payer to do so. And of course, we're living in the Dutch context here, so we have a lot of nice administrative data, so we can look at quite some different outcomes. Okay, let me tell you a little bit about provision of social care in the Netherlands. So the care for older individuals in the Netherlands is a shared responsibility of 3 different systems. So the health insurer is responsible for what I will call home nursing. So that means a nurse that comes to your home for specific medical treatments, like an injection or wound cleaning or something like this. Then we have a public long-term care insurance, a national insurance. That's basically for institutional care, so nursing homes. And then we have the municipalities. Now, since 2015, we had a big reform in 2015, and since that reform, municipalities are responsible for social care based on the so-called Social Support Act, or WMO in Dutch. And the interesting thing is that social care is a provision in the sense that these other things are really insured entitlements, right? So you have an insurance and you have entitlements to specific services and specific conditions. Let's say in theory, municipalities have a bit more space to decide what you get or what you don't get. So there can also be some variation actually across municipalities. And that means they have some freedom in contracting services, the way they design the eligibility procedure, but also the way that they levy co-payments. Now, in practice, what we've seen is that municipalities find it very difficult to kind of tailor-make this decision process. So there have been a number of court cases, for example, that have forced municipalities to really kind of give the same level of care to the same level of the same kind of patients. So they find it very difficult. So that means in practice, these co-payments are, let's say, the most concrete way in which they can actually differentiate on social circumstances apart from, let's say, the underlying health conditions of individuals. So what does social care look like in the Netherlands? I like this picture because it symbolizes very well what kind of services the social care is providing. So you see a stair lift, you see help with cleaning, you see help with cooking, but you also see transport to, for example, some daycare activities. So in the Netherlands, it includes domestic help, support, assistive devices and services like the stair lift or strollers, and short-term stays. And these care is provided through either general arrangements, right? So that means a municipality puts down a neighborhood location where everyone can come in and visit. That's kind of for everyone, and individual tailored packages where actually a specific individual gets, for example, 5 hours of domestic help per week. Now, what we're going to look at is mostly at these individual tailored packages because, you know, by the nature of these this kind of services, that's where we have individual data, right? So we cannot see who's using these more general provisions. So how do co-payments work in this system? So until 2019, municipalities were free to levy co-payments, but the design was kind of standardized. So co-payments you pay per 4-week care episode. So the care in this system is kind of always arranged in these 4-week episodes. And the amount of co-payment that you paid is basically the cost of the care, and then that is kept depending on your level of income. And I give some examples here of what this looked like. And for example, I think this is 2017 or so. So someone with an income below 20,000 euros, they would pay 1750 per 4-week care episode, so basically per month. Someone with 30,000 euros would pay up to 140 euros, and someone with an income of 80,000 euro would even pay more than 600 euros per care episode or per month, right? So there was really the ability to really differentiate according to people's income. So most municipalities levied co-payments, so they had the freedom not to do so, but most did. But some did use lower maxima. So for example, they would kind of put this income threshold a little bit lower so that also these higher incomes wouldn't pay 600 euros, but maybe 400 euros or so. So what happened in 2019? We had a big reform, and basically there was kind of a broad political concern about out-of-pocket costs for chronically ill, not necessarily only people using social care, but in general the idea was these people with chronic illnesses, they use different systems. They use the healthcare system, the social care system, maybe the long-term care system, and then all these systems actually they have to pay co-payments. So if you add that all up, that might be too much of a financial strain. And basically what I think happened is that the policymaker looked at kind of what is the easiest reform we can do to kind of do something about this. And then they said, we're going to kind of restrict this copayment for social care. So basically what they did, they abolished the copayment and replaced it by a uniform tariff of 1750 euros per month, basically. So where before you had these differences across incomes, basically now everyone only had to pay the 1750, which was kind of equal to the contribution for the lowest income group. Now you might wonder who is this guy there on the right. That was the Minister of Health, Hugo de Jonge at the time. And as you can see, he is a very optimistic kind of person. So even when this reform was introduced, a lot of people like me said, but you're kind of lowering co-payments for kind of social services for higher income groups. Aren't you afraid that that might lead to overuse of these services by the people that you don't really want to target? And as you can see, he said, no, everything, it will be fine. I don't think, they will go through the hassle of trying to admit for these services. Not worry, this will be good. And I think, I'm being a bit unfair to the minister here, because I think this was the broad political consensus at the time that this was really a wise decision to take, and we'll see whether they were right. So just to illustrate what happened to copayment, so what you see here is the average copayment among social care users per year over the different years and across different income groups. So the red line is the lowest income group, and then these other lines are the higher income groups. And you see exactly what I was just telling you, that prior to 2019, there was a huge difference in the annual copayments for people with higher incomes compared to lower incomes. And then 2019, basically, the copayment income gradient was totally flat. And, if you know anything about different diff analysis, you can already feel what's coming, I guess. So we have this group, the lower income groups, where nothing really changed. And we have these other groups where it changed. So we have a nice control group to analyze the effects of this reform. Another kind of descriptive I want to show you is just the increase in the total number of users. And I guess it's only single users. So you can see that up till 2018, it was kind of equal, a little bit less than 200,000 users. And then after the reform, it went up to almost 270,000 euros. So this users. So this is, of course, not a causal effect, but you can already feel, that this is quite a big jump. Okay, then I'll talk a little bit about the analysis. And first, the data. So we use administrative data on all Dutch 65 plus in the Netherlands. And we only look at singles. And we do so because basically calculating the copayment for, let's say, multi-person household is really a pain. Because you have to take a lot of things into account. So we have to do this at some point. But it's really difficult and also quite difficult to explain. So we'll focus on singles for now. And we look at the years I actually show you 2016 till 2022. So the year after the big reform in 2015, all the way up till 2020. We have two sources of information on social care use. Both have their pros and cons. I will talk about this in the next slide. So we actually have claims data. So that's collected actually to be able to collect the copayments from the users. So we have administrative data on that. And then there's a municipality survey with more detail on the services provided, also on the individual levels. But municipalities can choose whether they participate in this or not. Then to this data, we add different other data from the administrative sources that we have. So we have income data from the tax services. We have some data on socioeconomic background. We have data on other type of care use. So that's kind of to look at preventive effects. So we have cost of home nursing. We have nursing home use. And we also have medication data that's used by the health insurer on the ATC4 level. So we kind of have a classification of medications. And we use a procedure designed by Huber and co-authors to classify people in chronic disease groups based on this medication data. And that allows us to say something about the heterogeneity and effects across different groups based on their health, basically. So what is the main data issue that we have? So we have these two data sets, but the coverage varies over time and also between the two sources. So we have this claims data, but not all municipalities have copayments in every year. And if they don't have copayments, you're not in this data set. And not all services are covered by copayments. So sometimes, for example, this transport services, you might just pay, for a single ride, €2 or so. And that's not based on the copayment. And that might change also over a year, right? So 1 year it might be covered by the co-payment and 1 year it might be not. And we also have no data on the type of service in this data set after 2020. So then we have the survey data. The coverage in the first couple of years was relatively low. I think about half the municipalities. In the later years, almost all municipalities participate, and then we have quite a good coverage. So basically what we do is we kind of build a data set for municipalities in which we have the necessary data in either of these data sets at each point in time. And we exclude some of the services for which we know that some municipalities didn't levy co-payment or not in all years. And you can think, for example, like I just mentioned, the transport services are taken out to ensure that we're not taking into account services that are not falling under the co-payment. And we do a number of robustness checks. You know, if we only use one data set versus the other, I won't show these, but rest assured that our main results kind of stay up when we make other choices. Then something about the estimation strategy. So like I said, it's basically a pretty standard diff and diff. So these lower incomes already paid $17.50 per month, so they are not affected directly. So this is the natural control group. And then what we'll do is we look at a certain outcome. We do this all on the annual level. So do you use any care within a particular year? And that is a function of whether you're in the treatment group, you know, whether you're above this income threshold where you're actually affected by the reform. Then we have our calendar year dummies to capture general time trends. And we have the calendar year treatment effect interactions, which then should be the effects of the reform. And of course, what we hope is that before 2019, these things are all not significant, so that we don't have any pre-trends and we believe our design. And after 2019, then we are capturing the effects of the reform. We also include some covariates, namely age and gender. And the other thing we do is that we include estimation weight. So you can imagine that, you know, by construction, you know, we're looking at people with very different income levels. There might be some compositional differences between the treatment and the control group. So what we do is we define weights such that in each year, the distribution of gender, age, and chronic illness is equal in the control group compared to the treatment group. So basically, we weigh these different groups up to the treatment, let's say the distribution of the treatment group. And we do this in a stratified way. So we kind of do exact probabilities based on gender, age, and the level of chronic illness. And important to note, all the results except for the next slide that I will show you are based on this weighted population. So I won't show you too much unweighted things now. Here you see kind of the main descriptives. So you can see the treatment and control group obviously differ in levels of income. So the control group income is around 16,000 euros. So that's a bit above, let's say, the state pension level. And then for the treatment group, it's much higher. But this is still unweighted. So you can see that here there are some compositional differences. So the control group are more females. They're also a bit older. And they have some more chronic illnesses. And they also use, when you look at the bottom part of the graph, they also use a little bit more of different types of care. So this is what happens when we weigh these differences. So I didn't put any stars or so, but when we weight, all these kind of things that we weigh on naturally are not significantly different anymore. And you can see the income difference, of course, remains, but the kind of the population composition in terms of chronic illness, age, and gender is now kind of fixed. And you see that kind of the differences in healthcare use, they're a bit smaller, but they're still there. But that's also partly endogenous, right? Because they're faced with different co-payments at different points in time. You can also see we have quite some observations. So around, I think this is on an annual level. So we have about 1.1 million people in the treatment group and about 600,000 per year in the control group. And then let me move to the results. So here's the descriptive of the trend in social care use by treatment status. So we have the red line, those are the people in the lower income groups. And then we have the green line, the treatment groups of people above 20,000 euros. And what you can see is that, of course, there's a level difference. So the lower incomes, they use on average more social care. But you see the trends prior to the reform are pretty similar. And then after the reform, you see that the green line kind of, maybe because of the axis is not that clear, but you can see the green line moving up towards the red line, and that would then be kind of the increase in use due to the reform. And here you see kind of the coefficient estimates that that show this more clearly. And so this is our model based on the regression. And what you see basically before the reform, we don't see any differences in trends. And then after the reform, we see that actually in the treatment group, so among the higher incomes, the use of social care increases by 6 percentage points relative to the control group, right? So we see that these higher incomes starting to take up more social care. Then you might think, hey, this is the same graph, but here I only look at domestic help. And the point is exactly that it looks very similar. So we see that when you look at the effect for domestic help, that's also about almost 5.5 percentage points. So almost all of this increase in social care use is actually due to increases in domestic help and what I call, it's not totally true, but what you could see as house cleaning, right? So that's kind of already to get the main message of the paper. Because of this abolishment of co-payments, we see a substantial increase in the use of cleaning services provided by a public funder, right? So that already answers your question. Is this a good, was this reform very well targeted? Maybe not. Oh, but okay, we'll go to other results to kind of substantiate this point. So let's look whether the reform actually had some preventive effects. So did it decrease other types of care? And here I will always show you the trends next to the estimates, because as you will see that sometimes the estimates are a bit wild, and then the trends can show you why this is the case. So we still have to work a little bit on this. But here you see annual cost of home nurses. So this is this nursing provided at home by the health insurer. When you look at the raw trends, you basically see really nothing going on, so very parallel. When you look at the estimates, you see a little bit of pre-trends and a little bit of an effect, if you would believe it, afterwards. But I think the main takeaway is here, the effect is very small, right? We're talking about around 50 euros. It's also very noisy. And when you look at the total, I mean, if you look at the treatment group, they use around 1,100 euros, so 50 euros would be a very small effect compared to the mean. Then we can look at the effects on nursing home use. So this is, we're looking at a population at the start of the year is not in a nursing home, and then what is the probability that they will end up in a nursing home during that year? And again, you see the trend is a bit wild, so we still have to figure out what's happening in the control group in these later years. But also note that the axis is very small, right? So we're going from 2.6% to 3.2%. So it looks a bit wilder than it might be. So if you would believe, if you put this in a different diff, you do see kind of a decrease in the use of nursing home care, but as you can see, this seems to be driven by the control group, not by the estimates. So I don't want to give a too definitive answer on the nursing home use, but I would say it seems unlikely that it really had a preventive effect there. And then I like this one because we often overlook this because we don't have administrative data on this, but we have some health surveys. So this is a repeated cross-section, so different people every year, but still it's also smaller. I think it's like 10,000 observations or so each year, maybe even less. So it's a bit more noisy, but here we can see, did something happen with informal care use? Because that's why I actually would expect some of the action. And what you see again, we see that it's quite noisy because of the kind of sample that we have. But when you look at the effect estimates, yeah, we're a bit underpowered, right? But you see actually the point estimates here are quite close to zero. So it doesn't seem that the reform has led to a decrease in the use of informal care by these people that are now taking up all this domestic help. Then I want to say a little bit more on how well targeted the reform was, so that we at least reach the right kind of groups in terms of income, in terms of chronic illness. Well, let's have a look. So first, this is kind of the main effect again, now split out by different income groups. So instead of having one income group, we now have three, all relative to the same control group. Because of course, the higher your income was, the bigger change you had in the co-payment, because before it was income dependent. So if you were very rich, you faced the largest decrease in price. At the same time, people with higher incomes might have less need for some of these services. So we don't know what kind of these two effects will dominate. And what you actually see is, you see this green line is, let's say, the lowest affected treatment group, the blue line, the middle group, and then the purple one on the bottom is the highest income group. And you see the effect is most strongest really in these middle incomes. So it's not that the super rich, well, I don't know whether 37,000 already qualifies as super rich, but say it's not the most rich that take up these services the most. They also do so, but it's mainly in these more middle income groups that you really see these increases. So, well, at least that it's maybe a little bit of good news. Then also we can do kind of a same split up. We're now looking at chronic illnesses. So basically what we did, we now divide everyone up based on this medication data, whether they have chronic illnesses or not. And I think here the cutoff is 2 chronic illnesses because we're looking at an older population, right? So if you have more than 2 chronic illnesses, you're here in the red line, so the top line, and otherwise you're in a non-chronically ill group. And you do see that the effects is much stronger in this chronically ill group. So we do see that these municipalities, of course, still target these services to be based on some kind of underlying need, right? So it's not that if you're perfectly healthy, you will qualify for these services. So we do see that the people who are more ill, they are most affected by this reform. And then this is a bit more difficult picture maybe, but like I said, kind of the whole idea of this reform was to kind of decrease financial strain. So what we try to do here is kind of find a measure of financial strain. So what we do is we add up all the co-payments, so for the curative system, for care, for social care, and for long-term care, and then we express that as a percentage of income, and then see what changed. And I think the left graph, maybe we shouldn't let the x go all the way to 1 now that I see it, but I think it makes the right point. Not a lot happened in this average financial strain. And when you go to the right, so this is the effect on, let's say, financial strain, or the share of your income spent on co-payments compared to the control group. And you do see that it decreased a little bit. So again, point estimates are quite small compared to the baseline mean. But we do see a little bit of decrease in let's say, the co-payment spending among the treated groups. But I think more importantly is to realize that here, if you look at the left hand side, the control groups, or the lower incomes, are actually the ones who have the highest share of co-payments as a percentage of their income, right? So that is actually the group that's not affected. So maybe here looking at the effect estimates only tells us so much, right? It's really the kind of, we might have a little bit constrained the financial cost for these higher income groups, but the control group is actually facing similar or maybe even a little bit higher financial strain than before the reform. Then some sensitivity checks. So let's see whether this castle is really made of stone or not. I will only show you a little bit. One thing, of course, as you might have seen, we don't have that many pre-trend years, right? Because we have this reform in 2015. The data in 2015 is not really good yet. So we only have 2016 till 2018 to look at pre-trends. But one thing that we can do is we can do the same analysis on the quarterly level. So at least we can see whether there's any action, for example, right before the reform already. And as you can see, actually, it looks very well behaved. So really this effect, this is what I can show you. Also on the quarterly level, you see kind of no evidence really of pre-trends, and you see strong effect afterwards. The other thing that I want to show you, and again, this might be a little bit more difficult, but one thing we've been a bit concerned about is kind of general equilibrium effects or spillover effects. So you could think, okay, but if I'm in a municipality with a lot of high income people, and now all of a sudden I'm faced with this huge increase in demand, how am I going to finance that? So maybe I'm going to cut services to these lower income groups, right? So then our control group might be affected. So there are different things that we can do. I'm not so sure yet which one is the best, so maybe you have some ideas as well. But what we do here is basically we split up the municipalities based on the share of higher income in their population, right? So the idea here is that if you only have a few higher income people in your municipality, you're not really affected that much as a municipality by this reform. When you have a large amount of high income people, you're very much affected. So what you see here is the green line is municipalities kind of below the median in terms of the higher income population, and the red line are municipalities above the median in terms of the affected population. And you see basically, and we do kind of this analysis, control versus treatment for these two sorts of municipalities separately. So these are basically two different regressions. And what you see is actually the effects are very similar. So it seems that we still have to figure out what municipalities then did to finance this, but it doesn't seem to affect our estimates that much. So that's good news for us, I guess. And then I come to my last slide. So the conclusions, so is this a reform gone wrong? Well, I think at least what we see is it was not very well targeted, right? So it's mostly the higher incomes that started using publicly provided social care, mostly driven by domestic care, so house cleaning and these kind of things. Really the things that you would expect these groups to be able to take care of themselves. And we find, I would say, limited or maybe even no effects of prevention of other care. And also we find little on, let's say, the protection against financial shocks for older people. And I think by now policymakers also seem to agree. That's not due to this paper, by the way, but I guess more common sense. And there's now, the plans are now to reintroduce these co-payments in 2026. Although I have heard that still some people are still convinced that this was a good reform. I think now the political consensus is that it's going to be abolished. And then two open questions that we still want to look into. So first of all, I was already talking about this a little bit and also related to our bigger projects on municipality finances. So where did these financial resources actually come from? So how did municipalities then pay for this extra use of services? You know, did they stop repairing the roads or, you know, don't clean the parks anymore? Things like this. Maybe the impact is just too small to really matter that much for the municipalities, but we're still kind of looking into this. And the other thing, and that's, I think, also very interesting, but again, I don't know how far we will get, is where did this labor supply come from? And we have some anecdotal evidence that, for example, people who have a cleaning lady, they often pay for this, let's say, on the black market. Sometimes they're actually approached by these companies that say, but if you apply for social care, we can hire your cleaning lady and you have to pay less and it's all legal. So we have some supply-induced demand stories there. I don't know how large this is, but I think it's very interesting to see a little bit more, you know, are these people that came from, for example, cleaning services? Is this new labor supply, or at least legal labor supply? So that's something I think that would be very interesting to look into in the future. And that's, I think, what I had to say, and I'll stop sharing the screen. Yeah.
Thank you so much. And I'd like to introduce my colleague Bo Hu, who's from the Care Policy and Evaluation Center at the School of Economics, who's going to chair the Q&A. So Bo, you're in charge of finding questions, and thank you so much, Bram, for an excellent presentation.
Yeah, thank you, Adelina, and thank you again, Bram, for the wonderful presentation. So yeah, now we are open for questions from the audience. Adelina, I see you.
I have one. Sorry, I've been from the very beginning. I've been wondering, because from looking at it from the perspective of other countries, it seems remarkably generous how many people get help with domestic cleaning, you know, with cleaning. And I think, and for me, the question is, could you say a bit more about the eligibility criteria? Because they seem to be quite different than what we experience, for example, in the UK and in Spain, and other countries I'm familiar with.
Yeah, that's actually what I forgot to say. As I think in many countries, sometimes I think people also look a bit envious at our system, in the sense that I think what's good about it is that we actually provide kind of services that are not only medically oriented. So I think there's really a group there that benefits more from the side of provision of social services like this than from clinical services. So I think that's good, but then there's the issue of targeting. I think we have to spend a little bit more time and effort in explaining better exactly what the criteria are. In general, I would say they're quite vague. I mean, of course, disability, like in any other country, is kind of at the heart of this. So kind of the demand, kind of intrinsic demand coming from your health for these kind of services. But it's not the case that there's also, by the way, for nursing home care, not the case in the Netherlands, that there's a formal list of ADLs that qualify or not, or that you can kind of, you know, calculate a score. So that's not there. But of course, health is at the heart of it. And the other thing is, and that's a difference, for example, with the nursing home system, where basically the eligibility is only determined based on health, that for the social care, the idea is what we call kind of the kitchen table talks, that actually someone from the municipality or from the provider has a talk with the client and their family and informal caregivers. What can you still do yourself, and what do you really need formal services for? But like I said, in practice, I think many municipalities struggle in really kind of fine-tuning that. So to some extent, it's much easier to say, okay, everyone with certain disabilities will get X hours of house cleaning than when they have to explain, sometimes also in court cases, why does this person does not get house cleaning and this other person does get it. Yeah, so I don't think I totally answered your question, but maybe I gave a little bit something related to your.
Yeah, and I think it's about the balance between targeting by need or by income, and I think it's quite interesting to see that, because I think that's the dilemma for the Netherlands, potentially. Maybe other questions. Sorry, Paul, I've taken over the asking.
No problem, Adelina. And any other questions from the audience regarding the research findings or this presentation in general? I think it is really interesting to see that after the reform, we see pretty obvious increase in the use of domestic support and social care. But in terms of the nursing services and informal care, we didn't see a particularly strong pattern. And I think this makes me wonder to what extent unmet needs might play a role in this process. That is, some people, they may receive nursing services at home, or they may receive informal care. At the same time, they receive social care. But that doesn't mean that the services they have received have fully met their needs. It is just now that because co-payment it has decreased, and that they have the ability to use more services that makes their social care needs more fully met. And that might be one of the reasons why the informal care and the nursing care, because the needs is always there, and they always need those services to meet their care needs. So I just wonder whether you have the chance to look at the data, to look at the unmet needs side of things.
Yeah, I think that's a good point there. So it was also a bit on purpose. I exaggerated a little bit, let's say, the policy conclusion to also kind of, get some discussion going. But I think you're right. So I think what we show is, is among higher income groups, the kind of services that we see, I think make it likely, I would say, that this is really oversupply. But I do get the general point that I mean, it could be that some of these people actually get now services that they did not receive prior to the reform, either to informal care or to other types of formal care. So yeah, so I do get this point. I'm thinking I don't know how much more we could do to kind of identify this, right? So I don't think we would have kind of a direct measure of unmet need there. So yeah, I mean, that's something that we could, for example, look at, okay, people with chronic illnesses or disabilities, prior to the reform, did they receive any informal or formal care, and after the reform, did they receive this? I think that's something that we can do. I think part of the issue is that I think, for example, our informal care measure is quite rough, right? So maybe some people that clean someone, if you clean your partner's house or maybe even your parents' house, I don't know whether everyone would include that here as informal care provision. But I do. So the general point I take, and I think we'll think a little bit more about whether we can strengthen the case, whether this is unmet needs or this is really over provision. Yeah, thanks.
Yeah, and please.
Yeah, I think to some extent my question is related to that. Great thorough work, Bram. And I want to go back to that question about, so you observed the difference in change in use across groups, and then you see an increase in the use in the higher income rates, right? And then there was a question of whether this leads to this is a new equilibrium under the co-payment, change in the co-payments. One condition is that, and you touched upon it, and that then also touched upon the unmet needs, is have you established that the supply of services is meeting demand?
That's a very good point. We know very little about, let's say, supply other than through what we see in the uptake of services. Yeah. And that's one of the things that also relates a bit to my final point about where did the labor supply come from. So I think we could do something on, let's say, finances and maybe providers, but I'm not so sure what how far that would get us. I don't think there's, for example, waiting list data. That would be a way to do this, but I'm not so sure that there's for social care we actually have information on this. But I do get the point again, and I think saying something about the supply side, I think would really strengthen the story. I agree.
Yeah, and it's related to unmet needs. And then the question is to whether or not you see an observed increase in use of services among higher income groups because they're pushing out the service of they're making sure that those with lower incomes can no longer use the same service. And that might be because they don't recognize their own need, or it wasn't a need, or they just being pushed out, and one way or another, maybe through payments via the black markets even. But just but I think the cost basis is to establish it. Are we talking about unmet needs, and is a supply sufficient to meet all demand?
Yeah, so I think the only thing we can say about this now is at the end I showed this analysis where I looked at municipalities with kind of more treated or less treated.
Yeah.
And now I only showed you let's say the treatment groups, but we can kind of also compare what happens to the control groups, so the lower incomes.
Yeah.
So do we see that in municipalities that are more affected, the lower incomes start using less care? We don't really find any evidence for that. But I have to say there's some issues with this analysis. So I think one thing that is also still on our to-do list is not looking at this intensity, but at the financial situation of the municipality prior to the reform. So if you're in a municipality with kind of bad, let's say, finances, do we then see, that kind of these lower income groups are pushed out because the municipality needs to finance the services for these higher income groups? So that's something that's still on the list that we can do. And then I think there's some, you mentioned some angles that might be interesting for further research, but I have to think about the data. Yeah.
Okay, Hansel, Javiera, then Cassandra. Hansel, please.
Yeah. So actually, it's quite related to the discussion that just went past. Correct me if I'm wrong, but the responses, the estimates that you showed are extensive margin responses, right? So it's basically counts of people. So I think one interesting avenue would be look at intensive margin responses, and that may actually speak to like the open question about, where's the resources coming from? Because especially for like home-based care, you can imagine that the municipalities may be adjusting in terms of being, like you said, it's a provision, so they have some discretion in terms of commissioning like how many hours that they're willing to commission. So I don't know if there's any way to look at it. And I guess another thing that might be interesting to look at is if you can find like any change in composition of like disability or illness after the reform, because again, like you said, if they have some leeway in terms of eligibility criteria, that might be another margin to which they do it.
Yeah, thank you so much. I think the second point, we actually did look at this at some point, but we didn't really know how to interpret this. So I think your suggestion might lead us to revisit that, because I think what you're saying makes sense. And I think the first question you actually already asked me earlier. And now I realize that we didn't do it yet. So this is a good reminder. But there's also a reason for that. I think I said, this municipality data really is a pain. That's the thing. Well, if you're working in the UK, you probably know this. You have the same issues. That decentralized government also means decentralized data. So we've been really struggling making sense of the expenditure data, but we've made some steps there. So I think we can do something on the intensive margin now. One thing that we can do is kind of the number of care episodes, but I don't think that's the most important. But looking at kind of the spending per client, I think would be something that we potentially could do. But more homework for Stijn and Prithvi. So I see them both here. So I guess we will have a look at this. Yeah.
Okay, Javiera, you're next, I think.
Hi, thank you, Bram. It was very interesting. So you mentioned politics at the beginning of the presentation a little bit so I was just wondering, how do you think your paper, your result kind of fit to, I guess, the discussion in the Netherlands about whether co-payment kind of fit with the idea of providing public services? And yeah, so how do you think it will contribute to the discussion?
Yes, that's a very interesting question. I'm wondering how much I should say about this. So I think now there's kind of a bit of change in the political climate. So there was also in the long-term care space a bit. So there was this very much an emphasis on kind of aging in place, kind of self-proficiency of older individuals. We now have let's say, a minister in charge that is much more, let's say, in favor of publicly providing these kind of services to many individuals. But of course, then you run into issues about resources. And I have some, but you never know, especially in this political climate. But I have a little bit, I have this feeling that kind of differentiating more across the income axis instead of the, let's say, the need axis might be something that's actually now there's some political space for. So I think it's, to some extent, there is some space for kind of differentiating services across income groups and co-payments. Whether that really, I mean, levying co-payments is something no government likes to do because it's not politically very favorable. But I do think this kind of a bit of a shift in the way that we think about it in the Netherlands, that we should spend more time in, let's say, on the social circumstances and how to integrate that either in the eligibility or in the incentives than there was, let's say, 2 years ago or so. So maybe, yeah, I know it's a bit of an abstract answer, but that's a bit where we are, I think.
Cassandra, please.
Yeah, thanks a lot, Bram, for your presentation. I found it very interesting. And on the question of whether this reform was really so useful and given the effects that you've seen, I wanted to just raise the point, though. What about thinking about the welfare effects of abolishing co-payments? Just because we see a really large increase in the use of higher income groups, I mean, there could still be welfare gains there of having less financial concerns and still improvement in quality of life overall. So I just wonder if, before you write off totally that a reform is useless, whether you have considered also the potential welfare effects there. It sounds like, based on the data you have, maybe it's not possible to look at that, but I just wonder then if you've considered it.
Yeah, thank you, Cassandra. It also comes back a bit to the question that I think Bo raised in a bit different way. Yeah, what can I say about it? I mean, we have some well-being data, I guess, in the surveys, but I think that might be too broad for what we're looking at here. On the financial side, yeah, so I think what we showed is already, of course I can run a kind of, put some risk aversion in there, but to be honest, kind of the amounts we're talking about are very small. So if I put that in kind of standard econ welfare analysis, I'm pretty sure there's, the value of insurance here is very, very small, because the amounts are just too small. That doesn't, that we're working on a totally different paper with some other co-authors, where we're thinking a little bit more, maybe even, the insurance value is small, but you might still be very worried about the small payments, right? And it might still actually impact your welfare even beyond kind of expected utility. So that's a point, we're working on somewhere else. I was not really planning on putting that in this paper, but I think the general point also that I think very useful also from this discussion as a whole is that I think we have to be a little bit more conservative in the way we interpret the results. So I think it was good for me to kind of push a little bit in one direction, but when we write this up, I think we have to take into account that, there might still be some scope that that there are some positive welfare effects here as well.
Are there any other questions from the audience?
From perspective of long-term care financing and what we're trying to achieve. So let's go back to this dilemma between targeting by need. So if you have limited resources, you want to target those who need it most, and then you might look at the need for care, and then you might look at the financial need. But then if we think about a long-term care system, assuming that the system is financed in a progressive way, in a way, those who are wealthier have contributed most to the system, and they might expect then to also have access to the benefits from it. And so I think there is a bit of a question as to whether we need to strengthen to do this targeting by income, or whether it's enough to target by need, assuming that there's already been a redistribution in how the resources are raised. This is a bit of a devil's advocate point I'm putting across, but I think it's an important discussion and an important dilemma, and I just wanted to hear a bit more what your thoughts.
Yeah, no, and I think you're absolutely right, and I know maybe to give a little bit more detail to, let's say, the policy thinking, I think it was a bit along these lines, maybe not the wealthiest groups, but the idea was that, oh, if you have a middle income, you're kind of, basically stuck, you're not entitled to all these services that the lower incomes have, but you still, you don't have a huge income, you might not have a lot of savings, you're faced with all these kind of income dependent co-payments because everywhere you're just above this income threshold for all of these different arrangements. So I think it is indeed a legitimate policy concern, and maybe we have to say a little bit more about this as well. I think in kind of terms of legitimacy, I think here it plays a little bit less of a role than, for example, for the long-term care insurance, because that's really a social insurance, right, where you pay in premium. So this is more of a provision, so it comes from the general taxation and the municipality finances. But for example, we have the same thing in nursing home care. So if you have also their income and wealth-dependent co-payments. If you're very rich, you might pay up to 25 or 27,000 euros a year out of pocket, which I know for other countries is not that much for nursing homes, but in the Netherlands, context is really a large number. And then you have exactly the same discussion, and also the risk that at some point these higher incomes just opt out, right? So they just go to a private market, and that might actually lead to more inequalities than you started with. So again, I think this will help us. Saying something about this also in that when we write up the papers is really helpful in kind of bringing the nuance to it that it deserves. Yeah, thanks.
Thank you, Bram. Okay, I think we are reaching the end of this webinar. I don't know whether, Adelina, you have any concluding remarks or anything you want to say in the end.
Yeah, well, I'd like to thank you all. I'd like to thank you, Bram, for an excellent presentation, very thought-provoking, and I think it's a topic that we need to keep coming back to as more evidence emerges. And thanks for also highlighting all the work that's underway in this topic, and we'll be looking forward to your paper when it's published. Thank you both for chairing the Q&A. I'd like to thank Javiera from the Quasi-Experimental groups, who I know put a lot of work in organizing the webinar. We'll be looking forward to the next webinars from this interest group. We'll be announcing them in due course. And thank you, Naz, as well, from GOLTC, who makes everything happen. And I hope you have a good rest of the day, and see you at future events. Bye.